but I want all the residents to be able to get through their presentations. So I'm going to start. I'm going to start sharing my screen. Here's hoping it works. Let's see. And all right. Can people see this? If not, someone unmute yourselves and let me know.
Yes, we can see this.
Okay, great. And I'm assuming there are no announcements or anything that need to go out before I start. I see Stu's on here. Okay.
You're all set.
All right, great. So hello everyone and welcome to our resident presentation of their medically challenging cases. We have 8 cases to present to you, so I will try not to take too much time. With my introduction, the only thing I wanted to do was share with you a little information that I learned this week while helping to homeschool my 8-year-old. One of the things I learned, aside from the fact that she has the attention span of a fruit fly, is, oh no, my slides aren't advancing. Let me see, hold on, here we go. Is that, and this may come as a shock to many of you who are my age or older, but there are currently 5 world oceans. The Atlantic, the Arctic, the Indian, the Pacific, and now something called the Southern Ocean, which exists and is a question on geography tests for 4th grade that I could not answer. So there it is, the Southern Ocean, certified in 2000, apparently. We all agree that it existed and is named. It's the southern parts of the Arctic, Indian, and Pacific Ocean surrounding the Antarctic. You're welcome. Okay, moving on. Congratulations to all of our residents who had posters accepted to ASA this year. This is a list of everyone. If I have left anyone off, I apologize, but this is everyone that I have who contacted me. So congrats all of you. A portion of our residents were not able to present today due to scheduling conflicts, call, and vacation. And actually one of our residents is currently on vacation but is presenting. So thank you for that, Dan. All right, without further ado, we're gonna go in alphabetical order with everybody who is present. Andres, are you here?
Yes, I am.
Okay, I'm gonna start with your slides, all right? And just let me know when you want your second slide that has the algorithm kind of enlarged.
Sounds great. Perfect. So good morning, everyone, and thank you for having me here. I'm going to be presenting the perioperative management of patients with Ehlers-Danlos type 3 associated with postural orthostatic tachycardia syndrome undergoing general anesthesia. So these were 2 cases and a review of the literature. So let's start by saying that Ehlers-Danlos is an autosomal dominant disorder characterized by disorder of connective tissue. There are different types. There are some with more vascular involvement, others with more osteomuscular involvement. In our case, we're going to be focusing on type 3, which is the hypermobility and hyperelasticity characterized one. This syndrome can also be associated with postural orthostatic tachycardia syndrome, which is a condition characterized by tachycardia, orthostatic intolerance without hypotension. It's more frequently seen in young patients, in women specifically. The big part here is that when these 2 syndromes are together, or even separate, but in this case together, they can impose several challenges to the anesthesia providers, and they can bring several perioperative complications, and there are things that needs to be considered. So here we present 2 cases, 2 young female in their 20s, that underwent surgical procedures with general anesthesia. One of them got a cystectomy, and the second one a thyroidectomy. We can see that both were assessed at the Center of Perioperative Medicine, and their symptoms and their medical conditions were optimized before surgery. Something really important to mention is that the patient that got the thyroidectomy was actually pretty anxious, and these patients can be very anxious before surgery. She even brought a folder with recommendations for us, for their positioning, for intubation. She was very concerned, and Dr. Borovkanin did a great job reassuring her and letting her know that we were ready for her and we had everything that we needed. So in the intraoperative period, we talked with the whole team. We explained what was important, how important was to do good positioning. Both patients got standard induction with endotracheal intubation. We did video laryngoscopy to avoid neck extension and anterior traction. For the patient that had the thyroidectomy, we did an arterial line for hemodynamic monitoring. Both cases were very stable during the whole surgery. They had no complications. Emergence and extubation went uneventful. They were transferred to PACU after the surgery, and we talked with the staff as well regarding these positioning challenges. These patients were discharged home the same day without issue. So after debriefing and doing a literature review, we developed this management algorithm that summarizes and helps to the provider to manage these cases. So we can move to the next slide, please, which makes it bigger. Makes our Dr. Weber.
Yep, here we go. Sorry, I'm trying to get to the advancing part because my keyboard's not working. There you go.
So here we have our flow chart. It divides in the perioperative periods. So starting by the pre-op management, these patients should be assessed at a center of perioperative medicine to optimize the medical conditions. A thorough H&P and a physical exam are essential to optimize these patients. Identifying history of anesthetic complications is very important. Identified current non-pharmacologic and pharmacologic interventions for POTS. It's it's essential for their management. These patients may be very anxious, as we discussed. So good communication with them and their families is very important to be sure that they are comfortable with us and in the procedure. Talk with the patient about good hydration, NPO guidelines. All this is very important. For the intraoperative management, positioning, as we discussed, is critical here. And a good communication with the staff is important. We need to start by this. In terms of the induction, you can consider an arterial line in case that the procedure requires it, taking into account that these patients usually have these autonomies and they can be requiring this. Minimize hemodynamic instability. Adequate fluid hydration is very important. Use video laryngoscopy to avoid neck extension during intubation. Minimize eye pressure when taping the eyes. And provide an adequate fluid management. Do lung protective ventilation to avoid pneumothorax. Provide multimodal analgesia. And for emergence, be very gentle. Try to avoid rough movements and bucking. This will also help your patient to do better. In the postoperative period, for maintenance, there's any anesthetic technique is appropriate. There's no consensus about it. It can be general, regional, any type. For the post-operative period, again, it's important to talk with the PACU staff, let them know what these patients need. Monitor symptoms of hemodynamic instability. Take into account that if these patients develop tachycardia, yeah, they have POTS, but there are also other symptoms, other situations that needs to be ruled out before just considering that it's POTS, and encourage early rehabilitation. So this algorithm summarizes the management. You might think that this is not very common, but actually, after seeing these two patients, I had another one that actually had an LMA. And then 2 weeks ago, when I was giving a lunch break to one of my colleagues, she was actually taking care of a patient with both conditions. So it's more frequent than what we think. And this algorithm aims to summarize their management and will be probably very helpful in case you have to see one of these patients. So thank you very much for having us here, and I'm open to any question.
Thank you, Dr. Lacerna, for that very interesting talk. I do have a question for you. When you did the literature search, did you find any other literature associating Ehlers-Danlos with this POTS? I couldn't quite tell from your poster.
So what it's interesting of this study is that actually there are some documents about Ehlers-Danlos and considerations for them, and others for POTS. There are, I mean, this association is described as common, like it can happen, but there's no document right now talking about the considerations of both associations. So that's the new part of these documents. And that's what we found in our literature review. There's nothing like summarizing the needs for patients with this association, and you'll see that it's actually more frequent than what we really think.
Thank you.
Yep.
All right, moving on to Dr. Liu. Are you there, Sunny?
Good morning. Can you hear me?
Yep.
Okay. Good morning, everyone. This is a case of a 35-year-old female with a history of a tracheostomy tube who presented to our OR in hemorrhagic shock from a tracheoanomalous fistula, not once, but twice. 2 years prior, at an outside hospital, the patient presented with a cardiopulmonary arrest due to complications of urosepsis involving a prolonged cardiac arrest, paired with cervical fusion hardware that resulted in a high cervical cord injury as well as quadriplegia. Severe post-arrest tracheomalacia necessitated a long tracheostomy tube indefinitely. Sometime later, she presented to us requiring cardiopulmonary bypass for the tracheoinnominate fistula and underwent a venous bypass grafting for the innominate artery. Her postoperative course here was complicated by persistent sepsis as well as inability to wean from the ventilator. Approximately 2 months after her initial presentation to Strong, the patient experienced a tracheoinnominate refistulization with acute massive hemorrhage from the tracheostomy tube while in the ICU. ENT and anesthesia were emergently called to the bedside. The tracheostomy tube cuff was maximally inflated, and the bleeding was tamponaded with digital compression while the patient was emergently transported to the OR. Upon arrival to the OR, the patient was unresponsive, hypoxic, and virtually impossible to ventilate. She was emergently crashed onto VA ECMO and underwent innominate artery ligation via a midline sternotomy. Unfortunately, intraoperative findings showed a large mediastinal communicating tracheal defect incompatible with surgical repair. After multiple disciplinary meetings, the family chose to withdraw care a few days later because her postoperative course then was complicated by bilateral lower extremity and right upper extremity ischemia after the ECMO cannulation and the innominate artery ligation. This case reviews tracheoinnominate fistula, which is quite rare. The incidence is about 0.3% of standard cervical tracheostomies. Risk factors for this include prolonged mechanical ventilation, cervical hardware, and infection, all of which this patient presented with. Surgical intervention is absolutely necessary for survival of these patients, and even then, the survival rate is about 14%. To get the patient to the OR, adequate ventilation is critical, and techniques to facilitate this include control of the hemorrhage, really by any means necessary. Unfortunately, this patient did not have enough viable tracheal tissue to reconstruct a trachea, despite the swift surgical intervention, but it is a good academic review of all the things that must happen in order to give a patient an opportunity to survive. Thank you very much for your time. Is there any questions?
Thank you, Dr. Liu. That sounds like an extremely stressful and unfortunate case to have been a part of. Let's see. Next, let me make sure there's no questions in the chat.
Can you guys hear me?
Yeah.
I think, it might be helpful for Dr. Liu to tell us just a quick bit about options for controlling hemorrhage in these kinds of patients, because I see there's something on the slide.
Sure. So what you see on the right side of the, the left side of the picture was the original tracheotomic fistula during the original cardiopulmonary bypass surgery. And what you see on the left is actually one of the techniques by which the hemorrhage can be tamponaded. So you see, I don't know if I have control of the screen, but you see the tracheostomy site that's kind of this brown color right below the vocal cords. And then beyond that, you actually see an ET tube with a cuff maximally inflated against the hemorrhage itself. And that is one way to try to ventilate the patient. If you can get visualization enough, and presuming that the patient still has a structured enough trachea to get a tube in. The first time around for this patient, there was the opportunity to get a tube in. Unfortunately, the second time around, it took quite a while because the visualization was very poor and the tissue was even more friable than it was the first time. So there was a persistent leak throughout the second surgery because despite a maximally inflated cuff, the tissue was just very friable.
Thank you again, Sunny. All right, moving on to Dr. Pan. Are you there, Andrew?
Yes, can people hear me?
Yep.
Right. Morning, everybody, and thanks for being here and for your time and attention. So what I have here for my poster is a case report that I submitted with Dr. Pishardi. Basically, this was a case of a 41-year-old female who showed up to one of our pain clinics with bilateral thigh pain, so she came in for initial eval. Her history was pretty complicated, and she also went through a lot of trauma as well. She had avascular necrosis from tibial nailing for stress fractures, which are actually pictured in the picture in the middle. That's the nailing. She also had open biopsy of the right femur and cement augmentation for a distal femur neoplasm, which is what the yellow arrow is pointing to in the picture. Fibromyalgia, hypertension, PCOS. And we also focused in the title specifically on pigmented villonodular synovitis because of how rare it is. The incidence is actually 2 per million. So this was the also contributed to her pain. She had the PVNS treated back in 2001 and by synovectomy and radiation therapy. So she comes in with this complicated medical history for initial eval of this bilateral thigh pain. At presentation, she said it was about 5 out of 10. She didn't really give any specific description of the quality. It was kind of all over the place. She said it was constant, gnawing, aching like pins and needles, also sharp. Said it was radiating down her legs to the ankles, with the right side being more severely impacted, aggravated with activity and alleviated with rest. And functionally, she had a lot of heavily impacted her sleep and her work and her ability to go about her daily life. She also specifically mentioned the thigh pain was making it difficult for her to keep up with her active 2-year-old. On exam, she was awake and alert, no apparent distress, had an antalgic gait, and had tenderness to palpation at numerous points along her spinous processes, paraspinal muscles, and legs. So she did have intact range of motion and a normal neurologic exam, as well as a negative bilateral seated straight leg raise. Before she came to us for this thigh pain, she had undergone some recent trauma. So like I said, she had the stress fractures that she got nailing for. She also tried a combined total of 22 different pharmacologic and adjunctive modalities for her pain without much success or without lasting success. She tried a lot of different, she had tried NSAIDs with some effectiveness, but with intolerable side effects. Tried Tylenol, Tramadol. She tried massage therapy and chiropractic adjustments, and none of that was really doing that for her. So she came to us wanting to see what options she had. So when we saw her initially, we did our exam, and we decided to trial her on pregabalin and topiramate initially, because those were two medications that she had not tried previously before. And she ended up having dizziness and bilateral tinnitus in the month after she tried those medications. So after discussing other options, she agreed to trial femoral nerve blockade at our next appointment. So 1 month later, when she came back to us, we decided to undergo the femoral nerve blockade. We decided to target the right side because her pain was more severe on the right side. I think overall, the technique-wise, the femoral nerve block went pretty smoothly, and it was kind of a routine femoral nerve block. We ended up injecting 9 cc's of 0.25% bupivacaine and 40 mg of methylprednisolone. She ended up tolerating very well. There were no side effects, and at her 1 month follow-up appointment, which would have been 2 months after her initial visit, she reported very good relief. When asked to quantify her relief, she specifically mentioned a 95% improvement in her pain and functionality, and she was very happy that she could keep up with her 2-year-old. So I think overall, if I were to sum up this case, I mean, it was, I don't think that pain was particularly complicated. It was just that her history was complicated. And I think the PVNS was pretty interesting in that even though it was treated so long ago, but I think kind of the complications or side effects from having that treatment, specifically the radiation therapy, we thought caused her right side of thigh pain, because we thought she had that chondral lesion that at the end of her femur, for which she had other treatment for. And we thought that chondral lesion was probably related to the radiation therapy she had received for her PVNS. So that's kind of the gist of my case, and I'm happy to take any questions.
Andrew, what do you think accounts for the lasting effect of her relief from a femoral nerve block, which generally will last, 18 to 24 hours with the bupivacaine?
In this case, she probably had inflammation of the area, because we also did inject the methylprednisolone. So it was kind of like block that wore off, but then we had also injected steroid.
Okay. All right. Thank you, Dr. Pan. Next
Thank you.
is... sorry, guys. Hold on. All right. I think Dr. Wren is going over this one.
Yeah.
Okay.
All right. Good morning, everyone. Thanks for tuning in. So this poster is a case report of a patient with post-herpetic neuralgia that presented with recurrent painful muscle spasms. So just a little bit of review. So herpes zoster is reactivation of the varicella zoster virus, or chickenpox, that's lying dormant in the dorsal sensory ganglion. Usually first presents as chickenpox. The characteristic presentation would be a segmental rash, usually limited to 1 or 2 dermatomes, pain, and like sensory symptoms. Usually thought to be from inflammation in the ganglia, peripheral nerves, dorsal horn of the spinal cord. Usually the rash is preceded by the symptoms of pain, itching, paresthesias, any pain that lasts for more than 120 days after the rash onset is considered post-herpetic neuralgia. Thought to result from the viral injury to the afferent pathways. Rarely do we see motor symptoms. Usually we think of that sort of the sensory symptoms more often, but it has been reported more often related to central nervous system disease. even more rarely due to like a lower motor neuron issue. So this case is sort of an atypical presentation of postherpetic neuralgia presenting with severe muscle spasms in the T11 to L1 dermatome on the left. So this was a 58-year-old male who had a history of shingles for 3 weeks. He has other history of AML that was in remission. He had a bone marrow transplant. He had a renal cancer, had a left nephrectomy. So he's presenting with left-sided flank pain that radiated to the left anterior abdomen in the T11 to L1 dermatome. It was a 10 out of 10 pain, episodic, lancinating pain lasting for 1 to 5 seconds at a time. He was already on gabapentin, hydromorphone, and valacyclovir, which only provided him with minimal relief. On exam, he had a non-exudative rash with crusted lesions over the T11 dermatome that was very tender to palpation. So he was tried on the whole slew of treatment options, including lidocaine patches, a lot of our sort of typical pain medications, so nortriptyline, Lyrica, muscle relaxants, meloxicam, acyclovir, bupropion, and diazepam, all at maximal doses. A TENS unit was tried. He got an epidural steroid injection, a paravertebral block, and a tunneled epidural catheter at T11. The catheter was the only thing that really gave him any good pain relief, but of course it had to be taken out after 14 days because of infection risk. And he was also having some hypotension. And then over the next 5 months, the patient developed these painful muscle spasms in that area, in that distribution. They trialed him on baclofen and diazepam, capsaicin patch, Botox injections, and a tap block. And all of these only provided little to no relief. And if it did provide any relief, it was very temporary. So I guess overall, unfortunately for this patient, he never got any sort of lasting relief from any of the multiple medications or procedures that he was tried or that he was given. But just overall an interesting presentation of postherpetic neuralgia, which we don't usually think of as having motor involvement. So so motor involvement has been reported in 5 to 15% of patients with herpes zoster. There have been cases of diaphragmatic paralysis from phrenic nerve involvement, facial nerve muscles, extraocular nerve paresis, intercostal nerve involvement. Sometimes motor weakness can be the first symptom, but that can kind of delay diagnosis, again, because we're not used to thinking of postherpetic neuralgia presenting that way. They have shown EMG changes in 53% of patients in one study cohort of herpes zoster patients, which might suggest there is inflammation of the anterior horn and or anterior motor roots. And actually in those patients, it wasn't even confined to one dermatome. So I guess in summary, although there have been previous reports of motor involvement, this is what we think is the first case of reported severe muscle spasms or cramps as the primary presentation of postherpetic neuralgia. Any question?
Thanks, Karen. That was really interesting. I actually had not realized that discomfort from, and I'm sure this man was in more than discomfort, but that an epidural, like a prolonged epidural, was used for treatment for shingles pain. How common is that? Do you know?
I don't know exactly how common. I'm going to guess not very. I suspect this patient just they had tried just about everything else and just wanted to maybe break the cycle or provide him some relief to get him through it. That's why they tried that, probably knowing that it wasn't going to be like a permanent fix for him.
Okay. All right. I think you also have the next slide.
Yeah.
So I'm gonna. Sorry, hold on. There we go.
Okay, all right, so this is a case report of a subarachnoid local anesthetic injection during a retrobulbar block. So in review, I'm sure as we all know, so the retrobulbar block is a local anesthetic technique that is commonly used for eye surgery. They do it all the time, as we know, on the second floor, generally considered to be safe and effective. But there have been adverse events, including bradycardia, which we are typically on the lookout for, retrobulbar hematoma, optic nerve injury, and more serious events like CNS depression, cardiopulmonary arrest. In one study, they reported an incidence of 0.27% of patients who develop signs of CNS involvement, and 1 in 750 patients developing life-threatening complications. So there have been other cases described of subarachnoid injection of local leading to CNS and cardiopulmonary depression. So in this case, we had a patient who became unresponsive and apneic pretty soon after receiving a retrobulbar block. And this just goes through kind of the management plan for her, and luckily she had a good outcome. So this was a 73-year-old female. She presented for elective vitrectomy of the right eye. Overall pretty healthy, BMI of 30, type 2 diabetes, well-controlled hypothyroidism, hypertension. On the day of surgery, her exam was unremarkable, and she was planned for a max sedation with a retrobulbar block. She got 1 of Versed at the start of the case, then 40 milligrams of IV lidocaine and 25 of propofol in preparation for the block. The ophthalmologist performed the block, and within 5 minutes, the patient's blood pressure spiked to 200s over 90s. She was having chest heaviness, and the attending was called into the room. 15 minutes after the block, she became unresponsive. Capnography end tidal was lost. They started supporting her breathing with mask ventilation, and a stat was called overhead. They administered flumazenil twice, no change in the patient's mental status. They started intralipid as the bolus and then the infusion. She still wasn't breathing. They decided to intubate her, and her hemodynamic status stabilized over the next several minutes. Neuro and MICU consults were called into the OR. We got a 12-lead EKG, which was normal. SIVO was turned off after it was, end tidal was 0%. Neurology did an exam, which had revealed no response to verbal or tactile stimulus, non-reactive pupils, no cough or gag reflex. She was then taken to the CT scanner to check for any cerebrovascular events, and that was also negative. And then about 2.5 hours later, after the symptom onset, as she was being wheeled from the scanner to the ED, she started to regain consciousness. She was breathing and following commands. They extubated her to a non-rebreather in the critical care bay, and besides feeling a little short of breath, the patient said she felt well. The neuro exam 1 hour after she was extubated was normal, and then she went home that afternoon with no sequelae and no further neuro workup. In discussion, this is a subarachnoid injection is rare, but potentially very serious risk of a retrobulbar block. If you suspect it, requires swift intervention to support the patient's cardiovascular and respiratory systems. 2 proposed methods or possible methods of the subarachnoid injection. First would be via injection directly into the ophthalmic artery. Retrograde spread into the internal carotid, and that would typically result in extremely rapid symptom onset. Another mechanism would be direct injection into the optic nerve sheath and entry into the subdural or subarachnoid space that way. In that case, it can be a little bit slower symptom onset, which is, so that's why we suspect that's what happened in this case. Because it took about 5 to 15 minutes for symptoms to really kick in. And it should be on your differential, like a subarachnoid injection, but you should also be As in this case, the team did a really good job of working up other causes and treating other potential causes of CNS and cardiopulmonary toxicity. And the team was great about calling for assistance, calling for the appropriate consults, while also supporting the treatment and giving various treatments like flumazenil to rule out a benzo overdose, intralipid to treat possible last, EKG imaging, and for this patient, she ended up having a really good outcome. Any questions?
Thanks, Dr. Wren. That is a very interesting case. And Dr. Davis and I frequently argue about which of us has the larger black cloud. I think this puts him firmly in the running for first place. So let's see, next, unless anyone else has questions. Okay, next is Dr. Rubinger. You there, Dan?
Yeah, I'm here. Can everyone hear me?
Yeah.
Perfect. So I'm presenting a case with Dr. Bernstein called Not Out of the Woods Yet, a grave complication of pressure support in a redo cardiac surgical patient. Next slide, please. So very briefly, this is a relatively healthy gentleman who, 68-year-old with a past medical history of aortic stenosis. He previously had aortic valve replacement, hyperlipidemia, and depression, and he underwent a redo Bentall operation for a thoracic aortic aneurysm. Everything was pretty much going well. He was weaned off of bypass, and then intraoperatively, the TE noted a moderate to severe mitral regurg, which was previously noted as mild. They got a second opinion in the OR and they decided to actually repair it. So the patient was placed back onto bypass for the repair. And then everything else with the case was pretty uneventful. The patient went back up to the CVICU and was getting ready to be weaned off of the vent. And he was on a PEEP of 5 for a spontaneous breathing trial. So next slide, please. And this is kind of where things started to go sour. So he was on pressure support and relatively suddenly he became quite hypotensive, MAPS in the 45. He was still talking, conversing, but a little bit pale and ashen, and they noticed that the bilateral chest tubes were just filling up with blood. His MAPS continued to downtrend and he underwent cardiac arrest. The decision was made to reopen the chest at the bedside. They started intracardiac massage, massive transfusion, and they brought him down to the back to the OR on VA ECMO. They ended up identifying the site of bleeding as at the retrograde cardioplegia cannulation site. Intraoperatively, they saw significant clot burden in the LA, LV, RA, and the ascending aorta. And with family discussions, they decided to withdraw support and the patient expired shortly thereafter. Next slide. So the discussion was, we know that there was a tear at the retrograde cardioplegia cannulation site and causing a post-operative bleed. And we were just wondering if there are any forces at play in a spontaneous breathing trial or as part of weaning off of the mechanical ventilation that actually increases the likelihood of tears or pressure, something that could have caused this post-op bleed. Next slide, please. So we identified, oh, that's teeny tiny. But we identified a couple of physiological changes that occur when you're switching from positive pressure ventilation to negative. So the first is you switch to negative intrathoracic pressure, and that causes a bunch of different physiological changes. Specifically, you see increase afterload in the left ventricle and increase in systemic venous return, pardon me. Those are normally actually relatively good for the cardiac system. Additionally, the middle column shows that it's actually an increased work of breathing. This is pretty much a type of stress test. When you switch somebody to spontaneous respirations, you can see increased oxygen demand, increased oxygen consumption, and there's some, not reports, but there's some thought that you can actually risk myocardial ischemia because of the increased wall stress. And finally, that third column, just talking about the increased sympathetic tone, increased catecholamine release when you're switching somebody to spontaneous breathing. And this also will increase venous return and preload, putting other stresses in the system. Next slide, please. So the discussion was, we noticed in this case, the transition to spontaneous breathing coincided with the significant bleeding event. It's unclear whether it actually caused it or not. Maybe there was a coughing event, some sort of valsalva that increased the intrathoracic pressure and caused this tear. Nothing was documented, and we're unable to also find any other case reports documenting similar events that happened during a spontaneous breathing trial. But we have some evidence to support that there are physiologic changes that occur during a spontaneous breathing trial. Anything that could have been done differently, there's documentation of a hemostatic checklist, which is basically in the OR, you check to make sure that all the sites were actually, there's no bleeding anymore, which was done. And there's some evidence to support that higher PEEP could be used in the in mechanical ventilation while you're weaning to try to prevent post-op bleeding. That higher PEEP could actually tamponade some of the bleeding. That is a little bit controversial, but that's what some of the evidence suggests. And finally, on the last slide, the main take-home point was actually not so much about the physiology of the patient, but the fact that everything was going fantastic. And there was, this patient was thought to be just gonna have smooth sailing and then discharge, and all of a sudden we see this bleed and hemodynamic collapse. And they've had M&Ms and discussions about this, and they weren't really able to identify anything that they could have changed necessarily that would have altered the conclusion. So basically, we're not supposed to feel good after this case, but we're just supposed to realize that always have to be on the lookout for anything that can go wrong. And even when you just think you're just doing a basic breathing trial, things can go horribly, horribly wrong. So on that pleasant note, thank you very much for your attention.
Hi, I just wanted to make, this is Tisha, I just wanted to make a comment, and this is also in the spirit of sometimes when you go to conferences, people will ask you difficult questions. So actually, my first question is the hypothesis that during the spontaneous breathing trial, which you described as being on pressure support, that you were calling that negative pressure ventilation?
So I was using those terms pretty synonymously because the patient was triggering the breaths. So it's switching from yes, there was some level of CPAP, but I think the idea was that the patient was triggering the breaths. So it wasn't as, the positive pressure wasn't as pronounced as complete mechanical ventilation versus just pressure support.
Sure. I mean, I just want to point out that pressure support is a positive pressure mode of ventilation.
Yeah.
The patient does have an inspiratory trigger, which you can change. And so either it's flow triggered or pressure triggered. But those are both the same cases. I think the wider point I wanted to make, though, was if the hypothesis is that spontaneous breathing trial did this, is the hypothesis that if the patient had been left on a pure pressure-driven mode of ventilation or volume-driven mode of ventilation was deemed acceptable for extubation and extubated, that this wouldn't have happened with them spontaneously breathing without a ventilator being involved, is my question.
And I think that's a fair question. Initially, I think the thought was that perhaps, you know what, honestly, it's not clear. We tried to use this case to describe the changes that are occurring in mechanical ventilation and the basic heart-lung interactions. But given everything that happened, it probably would have happened anyways, quite frankly. So I'm not sure if the spontaneous breathing trial or the pressure support trial that we put the patient on either made it the bleed occur quicker or if it just happened at the same time. We don't know, is unfortunately the answer. It's not a very clear hypothesis. We were just using this case to try to understand what was going on.
It's an interesting case.
Thank you, Dr. Rubinger. Thank you, Dr. Munda, for your questions. We got 2 more cases to go to, so I'm going to move on. Our next one is Dr. Sohn.
All right. Good morning, everyone. This is Yujin, and it is my pleasure to be presenting this morning about the interesting case and the successful application of a relatively new regional nerve block to a chronic pain patient I submitted this work with Dr. Stoll, Dr. Tasker, and Dr. Lundermuth. Erector spine plane block is one of the newest regional anesthetic technique. This block was first described in 2016 as an effective treatment for thoracic neuropathic pain. Since then, ESP block has been widely applied to surgical procedures such as thoracotomies, percutaneous nephrolithotomies, hepatectomies, and bariatric surgeries, or even for the patients with chronic pain, both as a single shot as well as a continuous infusion via catheter placement. I met this 62-year-old gentleman while I was rotating in surgical ICU. This patient had chronic hepatitis C and multifocal hepatocellular carcinoma, and he was undergoing hepatectomy surgery. His past medical history is otherwise significant with obesity, pulmonary insufficiency, chronic pain with history of polysubstance abuse on Suboxone therapy. He was evaluated at the CPM clinic with anticipation of difficulty analgesia plan. He was advised to stop taking buprenorphine 5 days prior to the surgery. Basically, surgical incision was very extensive. The procedure was successful. At the conclusion of the surgery, patient received left-sided rectus sheath plane block and a right-sided transverse abdominis plane block. SICU, home dose of Suboxone and gabapentin clonidine were continued, as well as hydromorphone PCA, acetaminophen, ibuprofen. However, patient continued to report 8 out of 10 pain, diaphoretic. Any movement or breathing was just too difficult for him, and he refused to participate in physical therapy. On postoperative day 1, the APS team was consulted, and the right-sided mid-thoracic single-shot erector spinal plane block was performed using 30 cc of 0.375% bupivacaine. His pain dramatically improved to 2 out of 10 from 8. Following day, APS team returned, and they performed a right-sided thoracic ESP catheter. He received continuous infusion of bupivacaine with excellent pain reduction. Unfortunately, a catheter was inadvertently dislodged after 24 hours. During this time, his pain score remained between 2 to 5 out of 10. He was discharged home on post-operative day 6 without any complications. Liver surgery is associated with lots of somatic and visceral pain due to extensive surgical incision and rib retraction, diaphragmatic, and peritoneal irritation. Therefore, liver surgery ERAS protocols always include perioperative analgesia plan. Of note, Strong Memorial Hospital protocol includes preoperative gabapentin, postoperative TEP block, postoperative hydromorphone or morphine PCA, and optional spinal morphine. Pain management can be especially challenging in patients with chronic pain like the patient that I described earlier. Traditionally, postoperative pain is managed with acute opiate therapy and neuraxial analgesia. However, recent case reports demonstrate a successful application of ESP blocks in patients undergoing hepatic surgeries. In fact, ESP block is associated with reduced opiate consumption, decreased pain and temperature sensation with no reports of adverse bleeding side effect, hypotension, urinary retention, which are known side effect of neuraxial analgesia. So what is ESP block and how does it work? Can you please go to the next slide? So ESP block is an ultrasound-guided procedure. Local anesthetic is injected between the erector spinal muscles and the transverse process of thoracic vertebra. I don't know if you can see clearly, but the screen is the catheter and the tip is resting on top of the rib, but underneath the erector spinal muscle. So this illustration is from a study which compares local anesthetic spread from different anatomical studies of ESP block. The exact mechanism and spread of the mechanism is under debate, but it is believed that the dorsal and ventral rami of spinal nerves are the key target, and the thoracic and abdominal spinal muscles are blocked as a result. Spread of the medication to ventral or dorsal rami is shown in the figure F. And diffusion of the medication allows a multi-dermatomal sensory block of the anterior, posterior, and lateral thoracic or abdominal walls. Interestingly, some studies reported local anesthetic spread to epidural or paravertebral space, providing analgesia to visceral pain, which will be unique of this block. This is described in figure B. Even sympathetic chains were affected in some of the anatomical studies, as shown in figure D. ESP block is a simple block that can be performed at the bedside with minimal sedation or no sedation. Compared to TEP block, ESP block can provide visceral analgesia, and unlike epidural analgesia, ESP block can be safely performed in patients with thrombocytopenia, systemic anticoagulation, and considering that the liver patients often develop coagulopathic problems, ESP block can be the great alternative to other neuraxial technique for the anticipating acute surgical pain. Thank you very much for your time. I am happy to get any questions.
Thank you, Dr. Son. That's a very nice peripheral technique that can be used in patients with coagulopathies. I'm going to move on though because we have one more. Dr. Thandla.
Hello there, Dr. Weber. Can you hear me okay?
Yes.
Okay, perfect. So I'd like to present a case of unexpected cardiac arrest in a 73-year-old female who's undergoing elective rhinoplasty at Sawgrass Surgical Center. In general, intraoperative cardiac arrest is a pretty rare thing, but potentially catastrophic, and is associated with a pretty high mortality. It occurs approximately 7 out of every 10,000 non-cardiac surgeries, and 30-day mortality rates are consistently pretty high, between 60 and 80%. So here, just wanted to present a case of unexpected cardiac arrest in an elderly female undergoing elective plastic surgery at an outpatient surgical center. So this was a 73-year-old female with hypertension, type 2 diabetes, depression, and anxiety. Had a dog bite scar. That's why she was undergoing elective rhinoplasty. Initially underwent successful induction with 150 of propofol, 80 of lidocaine, and LMA placement without issue. But shortly after induction on her EKG, was noted to progress from bradycardia to asystole, and a code was called and ACLS was initiated. Each round of ACLS did result in a brief return of sinus bradycardia, which again progressed to asystole. It was determined that the patient had some kind of conduction abnormalities, since her heart rate wasn't responsive at all to epinephrine or atropine. Shock was attempted twice with no response in heart rate or blood pressure. Transcutaneous pacing was also attempted, but could not achieve capture. An A-line was obtained and an epinephrine infusion was begun. And after 6 rounds of CPR and after the start of the epi infusion, patient was bradycardic in the 40s, but with stable blood pressures, and she was transported via ambulance from Sawgrass to Strong. On arrival to Strong in the ED, chest x-ray did reveal a large tension pneumo, for which a chest tube was placed. But during chest tube placement, she once again went into PEA arrest with 1 round of CPR and epinephrine ×1. And since she was still bradycardic with complete heart block, cardiology was consulted and a transvenous pacing wire was inserted. And she was admitted to the ICU, initially requiring vasopressors and also treated for pneumonia. Her neurological status gradually returned to baseline and was extubated on day 10 of her ICU stay. And she was finally stable enough for a permanent pacemaker placement, which was placed on day 13. And her diet was advanced. We started on her home antihypertensive regimen and transferred to the floor after about a 2-week ICU stay, and discharged to long-term care facility for rehab after about a week on the regular floor. Presented a case of a 73-year-old female presenting for elective plastic surgery for a dog bite scar. This was a completely unexpected arrest post-induction. In terms of her prior medical history, kind of provides a few clues as to the etiology of why she arrested. She was a pretty standard ASA 3, relatively healthy without any major cardiac risk factors. And despite the high mortality rate after intraoperative cardiac arrest that's well documented in the literature, at least this patient had a good outcome, was luckily able to return to her previous level of functioning, had no persistent neurological deficits. So in the future, it'd be useful to explore outcomes specifically in the outpatient surgical center setting after intraoperative cardiac arrest. That's all I had. If there are any questions, or Dr. Weber, if you'd like to add your thoughts.
No, I mean, maybe Mike Davis and I are tied for black clouds. But anybody have any questions about any of the presentations? There's 5 minutes left. And we're happy to field them.
Yeah, just for this case, why was the patient shocked?
Because nothing else was working, Stu. We went through all of the ACLS. We couldn't get her back.
Right, but the patient was asystolic, correct?
I understand.
Okay. Just so the residents know.
Yeah.
Concern is you can make her more refreshed.
Asystole, it is ineffective to shock for asystole, but we were getting transient bradycardia. So at that point we were trying anything.
Oh, very difficult case, obviously, yeah.
Yeah, I agree. But you're right. In the ACLS algorithm for asystole, you do not shock. But she was not in constant asystole. She was going in and out of bradycardia, drifting to asystole. So she wasn't being textbook. Any questions about any of the other ones?
I was going to make a quick comment in response to Stu's comment. I wonder if the team might have thought that the patient was in very, very fine VFib and that it wasn't being recognized, and that might have been the reason for doing the shock.
I mean, we only had a 5-lead EKG. She could. I did not know if she was in fine VFib. It was always a possibility that it just wasn't illustrated well on her EKG. So, but that wasn't, Larry, that wasn't the reason that we shocked. So it would be a fine reason to shock. Anyone else? Any of the other presentations? All right, well, thank you to all of our residents who presented. That was very nicely done. And congratulations to everyone who is currently on or post-call and did not get to present. I hope your presentations at ASA go well. Thank you very much.